Hello everyone. Today with you, Dr. Rose, going to start the figure, the cancer updated by 2000 in the 2021. This is part 1 related to the cancer of a cervix uteri. So 2001 they make updated, and so first of all we have introduction. So globally, the cervical cancer is the continue to be is the common cancer among the female, who's begin to the fourth most common after the breast, colorectal, lung cancer. So majority of here the new cases of death approximately they found 85% to 90% respectively. So that will be occur the low and the middle income countries. So the low will be 85 and the middle income countries will be the 90%, whether the third most common cancer among the women. So anatomical consideration, the cervix is a lowermost part of in the uterus, and the uterus is a cylindrical structure composed of the stromal and the epithelium and the cervix, which is projecting into the vagina, and it is lined by the squamous epithelium. So endocervical canal, which can extend it from the internal os to external os, and it is lined by the columnar epithelium. And almost all of the cases, the cervical sarcoma of originate from of echo in the endocervical mucosa into the transformation zone. So this area of the cervix, it will be between the old and the new, the squamo-columnar junction. So this is area anatomical is very important about the cancer location, and even the cytological examination by the biopsy when we will take from this area. Even the surgically intervention, it is very important. So early detection and the prevention of cervical cancer. So here we have the rare and the long-term outcome of a persistent infection of a lower genital tract by about the 15 high risk of HPV and HPV types, which can term as a necessary cause of the cervical cancer. So persist of HPV infection denoted the presence of a same type specific HPV DNA on a repeating sample after the 6 to 12 months. So if the patient with the persistent infection, so here the present with the same specific type of HPV DNA, we have to be repeat by the sample at least 6 to 12 months. So more than the 80% of a woman over the time will acquired at least one HPV infection, and which is the show it is the unique nature and the ease of transmissions. Only the 1/10 of all infection become is a persist, and these the common would be developed the cervical pre-cancer lesion. So the estimation around 64,000 the new cervical cancer the cases. The cancer cases is annually in the worldwide. So here we have the HPV 16 and HPV 18 account 71% cases, while the types like 31, 33, 45, 52 and 58 account for another 19 cervical cancers. So most common we have the 16 and 18 cervical HPV cancers. That will be the 71%. This is for exam point of view, this is a very important. So here the two major strategies for prevention and early detection, namely like Hpv vaccination and screening for precancerous lesion. So WHO here initiate for elimination of cervical cancer is the public health the problem by the implication followed by the 90, 70 and the 90. So this is the triple pillar intervention strategy before year 2013. So it means the 90 to 70, then again 90. This is a triple the pillar intervention of strategies. Okay, this will be documented. Nearly around 90% incidence of HPV infections are clear within the periodic 2 years. So 90% HPV incidences cleared within the 2 years from the accusation of infection, and the persist only the 10% of the women. So this is a very the first 2 year is a very important for HPV incidence. So only the 2 year will going to be the incidence nearly is well documented in the 90%, and the 10% is going to women with the accusation persist. So the incidence, there is and the threshold will be the 4 per 100,000 women. So incidence threshold will be 4 per 100,000 women with the pragmatic elimination, the high income country by the WHO. This is by the WHO according. So 90% the girl, the fully vaccinated with a 2 dose of HPV vaccine by the age 15 year, and the 70% women is screened using is a high performance screening test is age the 35 and the 45 year. So here the 70% women is screened using the high performance screening by the age of the 35 to 45 year. So 90% women is detecting the cervical lesion to be receiving the treatment and the cure. So we will go to the primary in prevention in the cervical cancer with the HPV vaccination. So HPV prevalence is worldwide among the healthy women aged like 30 year in the around 11.7, with a highest sub-Saharan African and around 24. So if we will see to be the worldwide among the women age 30 will be 11.7. This is the percentage is very important, and they said with highest with the sub-Saharan African around 24%. So countries specifically the prevalence is ranging between the 2% to 42% globally. So age specific cross section HPV prevalence is a peak 8 the 25%, and the women the young than the 25 year, and the which can suggested that the infection is the predominantly transmitted through to the sexual routes and followed by the sexual debate. So thus the prophylactic like HPV vaccination is a prevention strategies that should be targeted the women will be initiate the sexual activity. This is especially the focusing on the girl the age 10 to 14, and this is the time is going to be the age specific 25%. First 25 year, they said according to this one. So here the prophylactic HPV vaccination, the threshold is going to be a strategy, especially the strategy vaccine to be threshold to the initiate the girls with the age of the 10 to 14 sexual activity. So focusing on the girl age and the prophylactic HPV vaccine is very important. So here the HPV vaccine was launched in the 2006, and 3 prophylactic HPV vaccine are the currently available for the use in the female and the male for age 9 for prevention of pre-malignant lesions and the cancer affecting the cervix, vulva, vagina, in the anus that caused by Hpv types. So this will be lesion, especially pre-malignant lesion where we can found this is a cancer is affecting the cervix, the vulva, vagina, and the anus that is caused by the Hpv types. So bivalent vaccine targeting by the 16 and Hpv 18, and the quadrivalent vaccine like targeting Hpv 6 and the Hpv 11. So additionally we have Hpv 16 and the 18, and the non-avalent vaccine like targeting HPV in the type this is the non-valent will going to be the targeting which type of others like 31, 33, 45, 52, and the 58 additional. So this is additional with the non-avalent vaccine will going to be the targeted for others. So additionally to be the HPV 6, 11, 16, and the 18. So in additionally here they said to be the last 2 vaccines Last two vaccine is going to target it as a genital ward by the HPV 6 and 11 recently. So here this additionally they make to be the two vaccine targeting by the genital wards caused by the HPV 6 and the 11. This is a recently bivalent HPV vaccine. The name is the Sequelin and Zymen and the Innovex biotech, and it has a license in the China currently undergoing to be the WHO. The qualification process is still, it is not to be worldwide recommended. So all of the vaccine is a recommended vaccine, the composed of a virus like particles and are infections, since they do not have a containing the viral DNA. So here especially the say for a girl and the boys the age 19 to 14, the 2-dose schedule will be, we will give 0.5 ml at a 0, 6 and the 12 month. Okay, the first dose will be start after the 6 month we have to be give second, and then 12 month is a third one. So here the second dose should be given as a 6 to 12 month after the first dose. This is the recommendation, and those age the girl with the though have the age is a 15 year or older than immunocompromised patient, and respective of age the must receiving the 3 dose. So here if they say to be the patient with the over age of the 15 or older and immunocompromised patient, and respective with the age they can use as a 3 dosage. 0.5 at 0, 1, 2 and the 6 month is part of the manufacturer recommendation which is the vaccine is they are going to be used. So WHO has the review the latest data and concluded that there is no safety concern regarding HPV vaccine. So secondary prevention of a cervical cancer by early the detection and the treatment of a precanceric region. Okay, here they said to be the secondary prevention by cervical cancer, the early detection and the treatment precanceric lesion. So early detection is giving to be the control of a disease. So here the screening is important strategy. So globally elimination of a cervical cancer, while the HPV vaccination aim to be prevent the cervical neoplasia by the preventing HPV vaccine. So screening aim to be detect the prevalent cervical precanceric lesions such as high-grade CIN and adenocarcinoma in situ in early, and effectively treat them to be prevent invasive cancer and decreasing the cervical cancer mortality rates. So here especially they're going to be give the importance about the preventing of cervical neoplasia by the preventing by HPV vaccine infection by the screening aim. So we have here the detection prevent the cervical precanceric lesion, and the high grade will not go to the high grade CIN, that will be the adenocarcinoma in situ in early, and effective the treatment treat them to be as a prevent will not go as in vascular cancer, and the decreasing the cervical cancer mortality rates. So this is the benefit. So we can be reduce the cervical vascular cancer and the decreasing cervical cancer mortality rate. So it will be therefore a remaining priority of a cervical cancer preventing for a several decades. So several we have cervical cancer and strategies has been the use effectively in the that is a varied setting. The conventionally cytology we have pap smear, and the recent year they are going to be used as a liquid based cytology, the LBC and the HPV testing. These are the new nowadays. So in LMIC, and that will be the visual inspection with the acetic acid. This is even the all is going to be now to be the patient is when they're going to be the clinical screening strategies. They are going to be in the settings they can go follow is the pap smear and the liquid based cytology, HPV the testing, and the LMIC and the visual inspection, and acetic acid. The while the screening they said to be the pap smear is a regular interval has been the resulting in a substantial declining in the cervical cancer in the risk high economic countries. So here the pap smear they said to be the cervical cancer is a high economic countries substantially going to be declined. So here the resources intensive need to be a repeat round of the compounds need for a poor sensitivity, and and it is not feasible. Feasible is a lower source of the setting where is the poor organization, the coverage is less, and the quality assurance resulting is a suboptimal outcome. So this is even the assessment and screening is very important to the standard of the healthcare according to be organizations. So HPV the based screening has been the higher sensitive and accuracy and the lower variability and the better reproducibility and the comparing with the conventional or LBC in the context of a declining HPV infection vaccinated population. So maybe the healthcare system are the watching to the primary HPV screening who have higher negative and predicted the value, allowing the extended screening interval or even the lifetime screening is the low source setting can be. So this is even the community acquired the situations and the conditions and the health facilities. So this is thus is increasing the colposcopic referral rate, but also the result is a higher detecting the rate of the CIN3 and the lesion in the cervical cancer. So here and they said to be the colposcopic referral rate is going to be increased because of the many legs of different sites, but also here the higher detection rate of the CIN3 mean the lesion is advanced condition is going to be a rule out. So why are the screening involve the detection of acito-white lesion on a cervix 1 minute after the application of a 3% or a 5% the freshly prepared acetic acid? This view of its feasibility, and it has been the widely implemented in the opportunistic settings and many of low countries in the sub-Saharan African. So we have a single visit approach, SVA, for screening with a rapid diagnostic and the treatment improving like coverage, elimination, follow-up visits, and improve the cost efficacy in the low sources of the settings. This is on the situation and the environment. So why have I the screening the particularly the suitable for a single visit screening approach, or WHO has been issued the guideline for implementing is a SVA public health setting. So the WHO is giving as a recommendation. So now I will go to be the staging of a cervical cancer. So we have invasive cervical cancer spreading by the direct extension. That will be the parametrium, vagina, uterus, and the adjacent organs like a bladder, rectum, and also spreading along with a lymphatic channel to be the regional lymph nodes. So namely they can extend as the obturator, external iliac and the internal iliac, and hence the common iliac and the para-aortic node involvement. So this when the going to be invasion of a cervical from the organ to the lymphatic, or the lymphatic to the organ can be involvement by the direct way. So the standard metastasis can be go lung, liver, and skeleton by the hematogenous route, and the late phenomena can be cervix was a first organ assigned as a clinical staging system cancer by the figure 1953 according to the stages of the clinical, and 1952 the first cervical organ will going to be assigned as a clinical staging. This is shown from the figure 1952. This is very old. So subsequently now the pathological the tumor necrotic metastasis staging follow, so which has been the used by the purpose and the documenting like nodular metastasis disease status. So in 2018 the FIGO Gynecological Oncology Committee revived the staging and allowing the option of the clinical and the radiological and the pathological finding and available to be the assigned in the stage. So here the corridenum of this stages were published. Therefore is some modification and reviving staging of a show. So here we have a table. They said to be the main the change are like horizontal dimension as a microinvasive lesion is no longer considered. If the table 1, if we will look this one, they said to be the horizontal dimensionally when it will going to be spreading as a microinvasion, the lesion is no longer considered. So here the tumor size has been thus stratified further in 3 subgroups. So we will divide the stage 1 we will make 1B 1 less than 2 centimeter and 1B 2 with the more than 2 are less than 4, and 1B3 will be the more than 4. These are the staging. They divide in the subgroups stages. So 1B1 less than 2, and then more than 2, then less than 4, and then more than 4. This is the staging they divided. So here the lymph node positive, which is correlated with a poor oncological outcome, against assigning in the case of stages like 3C and the pelvic node. So 3C1 and this will be going to be involved. 3C1 is a pelvic node and the para-aortic node is going to be 3C2. So micrometastasis are including the stage in the 3C. So if we will think about the 3 stage, so we have to be consider the microinvasion in the first of all, and second we have to be look, and if the 3C1 it is 3C, it can be the pelvic node. Okay, 3C1 will be the para-aortic node, and if the 3CB will be para-aortic and the pelvic node will be 3C1, and micrometastasis will going to be involved in the 3C. So here we have the histopathological for the cancer. This is essential that all cancer must be confirmed, the microscopical examination. So the causes are the classified and the carcinoma of a cervix. So primary growth of the cervix, all histological type must be including, like histopathological type describing as a WHO classification of genital tumor, female genital tumor. So if we will see this figure, this table given by the figure staging of a cancer in 2018. So this is according to this one we can understand more. So one group is again going to be A in A1 and A2. So here the cancer is strictly confined with the cervix, and 1A will be invasion carcinoma, can be diagnostic only the microscopic with the maximum depth is less than 5 millimeter. Okay, here if we will see them see to the 1A1 to be mere invasion of micro invasion. First of all, stromal invasion will go, and less than the 3 millimeter is the depth, and A2 will be the mere the stromal invasion more than the 5 and the more than the 3 and the less than the 5 in the depth. So will be 1B, because here they give the 6 classes. Okay, A and B, then again A will going to be divided in the 2 classes. This is less than 3 and more than 3 are less than 5. This is the one. Now B we have the invasion of a carcinoma mere by the depth, invasion more than the 5 and the greater than stage 1. So lesion can be limited with the cervix, uteri, and the size of the mere maximum tumor. So again 1B is going to be the 1B, 1, 2, and 3. So here the more than 5 carcinoma depth and invasion less than 2, and the B2 will be the more than the invasive carcinoma more than 2, and the depth will be they said to greatest dimension like less than 4 centimeter, and B3 will be invasion of a carcinoma more than the 4 centimeter and the greatest dimension. This is the dimension will going to be spreading. So if we will come to be the second stage that is a carcinoma invading beyond the uterus. It means here the beyond the uterus it is going to be the pass and not extended on a lower third of a vagina or the pelvic wall. And again the second stage is going to be the second stage A and second stage B, and the A again going to be divided A1 and the A2. So here the A2A is involved the limitation upper 1/3 of the vagina without the parametrial involvement. Okay, and if the A1 we will say this invasion the less than 4 greatest dimension. If the A2 will be the invasion more than the 4 greatest dimension, and the 2B will be with the parametric involvement but not to be the pelvic side wall, and the 3 will be the carcinoma involved the lower third of the vagina that will going to be extended the pelvic wall and the causing to the hydronephrosis. It means the kidney going to be infiltrated, or the non-functional kidney are involved the pelvic and the para-aortic lymph node. The stage 3 is a very important because here is the systematically going to be involvement by the organ, especially to the kidney. So here 3 is going to be A, B, C again, and C is going to be already we read it about the staging before to be the 3 is a very important about the pelvic lymph node metastasis, and the if we will see to be the lymph node is going to be even the change. If C1 will going to be the pelvic lymph node, and the C2 will be going to the para-aortic lymph node metastasis. So here the stage 4 is a carcinoma extended beyond to the true pelvis and involved to the biopsy proven mucosa and the bladder, rectum, bolus edema and such does not permit in the case of the allotted in the stage 4. So here the 4A and 4B again the spreading growth adjuvant pelvic organ, and B will be 4B will be spreading the distended organ. This the table is difficult to remember as it is, but we can understand when going to be the invasion beyond to the organ and the treatment. So we have here subtype of this one cervical cancer. So especially we will go to the squamous epithelial tumor. So squamous epithelial also we have the squamous cell carcinoma HPV associated, squamous cell carcinoma HPV independent, squamous cell carcinoma with the NOS. So here the glandular tumor adenocarcinoma with the NOS, and the adenocarcinoma with HPV associated adenocarcinoma dependent of gastric type, adenocarcinoma HPV independent, clear cell carcinoma. This is sub many types, and the adenocarcinoma HPV independent mesonephric type, and the adenocarcinoma HPV independent NOS, and the endometrioid adenocarcinoma NOS, and the carcinoma NOS, squamous carcinoma, and the mucoepidermal epidermoid the carcinoma, and the adenoid the basal carcinoma, and the carcinoma undifferentiated NOS. So if we will see to be the mixed epithelial and the mesangial the tumor like adenosarcoma, and the germ cell tumor will go even to be endodermal sinus tumor, yolk sac tumor NOS, and the choriocarcinoma NOS. So here to be the diagnosis and by the evaluation of the cervical cancer. So what can be, how we can be going to be the diagnose and go to evaluate the patient. So here the microinvasion, first of all, diagnose stage 1A, 1B, what we read this the table they give us many subtype of the stage 1. So the made 1A1 A2 will made of microscopic examination of a cone biopsy specimen, so that can help the leaf or the cold knife conization, which is including the entire lesion, and also the made on trachelectomy or the hysterectomic specimen, and the depth can envision and should not be the greater than 3 or 5 millimeters. So here is the depth envision even not going to be beyond 3 to 5 millimeters. So respectively, these bases of the epithelium that can be the horizontal dimension and the longer consideration in the 2018 revision, because this is updated 2021. So according to horizontal dimension is no longer considered in the 2018. Is it not has been the show and the impact the survival. So note the must be made the lymphatic vascular specimen involvement, which would not be the later stages and but may be affecting the treatment of a plant. So here such like the stages is going to be ultra, but effect of the treatment plan and the marginal should be reported to be the negative for the disease. If the margin is a cone biopsy or a positive and the invasive cancer, the patient is allocated stage 1. 1B1, because now here the stage is going to be the change if the positive came. So invasive disease in the case of the visible lesion and the pinch biopsy are maybe the generally is surface for a diagnosis, but not is satisfactory of a small the loop biopsy. So or can be the cone we can there is requiring can be is a cone biopsy, a small loop cone biopsy, or the cone may be required. The clinical assessment in the first step of allocation of staging. So here the figure 2018 staging permit the use of any image modalities according to available the resources and ultrasound like the CTA, MRI, and like a PET, and the providing additional information like a tumor size, nodular status, local, systematic spreading, and MRI, the best method radiological assessment. So primary tumor is greater than the 10 mm for a detection as a nodular metastasis. So here the size of the tumor, primary tumor, is very important. So here they said to be detecting the nodular metastasis, the greater than the 10 millimeter, it will be the PET, CT is more accurate than the CT and MRI. Here, if the patient, the tumor, primary tumor found the 10 millimeter, so here we are going to be, because we will consider this is the metastasis can be greater nodular. So we have to be go PET, CT, more accurate than the CT and MRI. So false negative result can become 4 to 15% cases. So in this the area, especially the high prevalences of tuberculosis and the inflammation, especially the HIV endemic areas, there is running in the HIV is endemically. So here is going to be the help. The large lymph node are not necessarily metastasis. The clinician may be decision is on images and the possible to be the needle fine biopsy and exclude as a metastasis. So especially this is the two advanced stages: surgical assessment, para-aortic lymph node, minimally invasion, and the surgical laparotomy can be used treatment according to extension of a disease. So surgical exclusion of a para-aortic the lymph node involvement has been reported by correct with a prognosis, the better, and the radiographical occlusion along with a figure no longer mandated of a biochemical investigation or the investigation, the procedure. However, this is according to Frank envision, they said the carcinoma, invasive carcinoma, especially the chest X-ray assessment and the hydronephrosis with a renal ultrasound, CT, and MRI should be done. This is by the Frank envision. So Frank, if the patient with came with a frank invasion. Carcinoma is going to be assessed as a chest x-ray and the assessment of a hydronephrosis, because here can be the renal involvement. So we have to do the renal ultrasound, CT, MRI should be done. So bladder and the rectum evaluation by the cystoscopy and the sigmoidoscopy only. The patient is a clinical symptomatic patient with a clinical by the rectal area. So we have to go as a according to need and systematic management the evaluation. So cystoscopy are also recommended in the case of the barrel shape endocervical growth, and this we can found by ultrasound in the CT, and also in whether the growth is extended to the anterior vaginal wall. So suspected here the bladder and the rectal involvement should be confirmed by the biopsy and the histological evidence. So here the bolus and the edema and along with that does not be warranted in the case of the allocated to stage 4. So here especially during the assessment we can find the many diagnose and the stage in early management. So now I will go to the management of cervical cancer. The management of cervical cancer is a primary by the surgery, radiation therapy, and the chemotherapy is available adjuvant. So here the surgical treatment, the surgery is the suitable for early stage, whether the cervical the conization and simple like a hysterectomy or the radical hysterectomy may be selected according to the stage of a disease. So this table 2 is give us to be guide about the type of a radical hysterectomy, and in this especially we say the stage 4A. And the selective cases may be suitable for pelvic extension. So here we have this table is give us a scenario about the type of the radical hysterectomy. Simply we will say the simple the extrafacial hysterectomy and the modified rectal radical hysterectomy and the radical hysterectomy. These are the 3 categories. If we will look to be the Pivor and the Rutledge classification, if we will say the simple the extrafacial hysterectomy, that this is the type 1. If a modified radical hysterectomy, this is type 2, and the radical hysterectomy, this will be the type 2. Even again we will come to be the classification like Correlin and the Morrow classification. These are the 2. They will give the another classification like type A, type B, and type C. So here the indication can be the stage 1A. This is the type A, or type 1. If the type 1A1 with the local invasion with an intravascular invasion can be involved, this is A12. Even this is going to be the type 2 and the type B. And if we will see the radical hysterectomy at the type 2 or type C, this will be the stage 1B and 1B2 and the selective stage 2A. So here the uterus going to be the involved, the uterus and the cervix. So here the simple, if the simple extra classification the type 1 going to be removal, uterus and cervix is going to be removed. Modified radical remove uterus and the cervix. Even the radical going to be removed. So here even the ovarian the 3 stages going to be optimally removed of ovaries, vaginal, but simple the extrafacial hysterectomy like type 1 or A will not going to be removed is vaginal, but the modified the type 2 will be optimal removal and optimal removal in both. So vaginal is safe in the simple on the stage 1. So vaginal margin is the same, is not removed in the simple, but the B type 2 and 3 is going to be removed. Ureter is not mobilized, non-mobilized in the type 1, but in the type 2 and type 3 will going to be type 2 is a 1.2 centimeter and the 3 will be the optimal room upper the quadrant of a 1/3, upper quadrant of the 1/3 is type 3. Ureter, okay, Ureter, they said to be not mobilized, but here type B will be the tunnel through to the broad ligament and the tunnel through the broad ligament. Both is going to be the type 2 and 3. So cardinal, deviating ureter and the cervical border, and B said the dividing whether the ureter transit with a broad ligament, but here the 3 will be divide, and the pelvic side wall is going to be divide. Cardinal ligament going to be divide in type 3, and the uterosacral ligament dividing the cervical the border, and the partially remove in type 2, and the dividing is near to the sacral region. And even the rectum, if we will see the same involvement of the stage 1 is not mobilized, but here the mobilized below the cervix, and even the type 3 is the same. So surgical approach, and the type 1 will go to the laparotomy and the laparoscopy and the robotic surgery. This is the stage 1, and the stage 2 will be going to be the laparotomy, laparoscopy, and the robotic same surgery here. Both. Okay, even third one, third stage, even the will go to the same procedure: laparotomy, laparoscopic, or the robotic surgeries. So now we have the micro envision cervical carcinoma figure, the stage 1A and 1B. According to be the figure, they said the treatment of the completed by the conization of, unless there is a lymphovascular space, a tumor will be the present the surgical margin. So here the complete the child, the bare region of older women, the extrafacial and the hysterectomy may also recommended, and the route can be choose are abdominally, vaginally, minimal, maybe the invasive, and can be the evident the pelvic lymphadenectomy should be considered along with the extrafacial hysterectomy. If the fertility is desired to be the patient is a cervical if the fertility is going to be desired with a cervical conization with the close follow-up will be adequate till the fertility desire will be then we'll go to another procedure. So this is the stage 1, 2. We have here the small risk of lymph node metastasis. So the pelvic lymph node perform as a type 2, and the radical hysterectomy, this will be the low risk. So here they say to be the simple hysterectomy, the trachelectomy combined with the pelvic lymphadenectomy, and the senile lymph node can be assessed by the surgically. So here the consideration they said to be envision with the evidence of the pelvic lymph node should be considered. Extrafacial hysterectomy can be, but if the fertility desire if they say to the if the fertility desire may be offered the choice of according to be like type 1, they said to be cervical conization with a pelvic lymphadenectomy like open or a minimal invasion of surgery. Or second, we have a radical trachelectomy with a pelvic lymphadenectomy by the with the abdominal, vaginal, and the MIS route. So post treatment of the follow-up, after the treatment, how we going to be the follow the patient after the fertility is fairing, the surgery follow-up within the 3 month pap smear for a 2 year and 6 month, then next 3 year. So first 2 year will be will go 3 monthly, 6 month for next 3 year. So recommended with a normal follow-up for at least up to the 5 year, and the patient can be returned to be the screening schedule again, and national is a national guideline according to this one, and the image and like further recommendation are not to be required, but here performed by the case by case according to the case scenario. So envision cervical cancer figure stage 1B is same as the surgical treatment, preferable modularity of the treatment of the 1B1 or the 2, and 1A lesion can be would be consisting of the type of radical hysterectomy or the pelvic lymphodectomy. So here going to be the figure staging 1B. Like they said to be cervical stromal invasion, the less than the 50% in the not suspicious lymph node image. So the standard recommended type completely radical hysterectomy, but the modified radical hysterectomy may be considered, and the pelvic lymphodectomy is considered when including the some high quality of involvement. So the pelvic nerve sparing and surgical procedure and recommended of undergoing to be the type of hysterectomy and radical hysterectomies and the radical curability of to be looked of carefully by the intrapelvic injuries and especially the autonomic nerve. So hypogastric nerve can be a splenic nerve, and the pelvic plexus can be going to be damaged on these all process. So we have to be improve the patient urination, defecation, and the sexual function, and the consequent of deorientation like post-operative the quality of the life of the female. We have to be look, and we have to be look the female with the desire of the fertility aspiring. So is radical hysterectomy by the performing by staging is the 1A2 and the 1B1 tumor. So here cervix long with the parametrium and the removal followed by the anastomosis of the uterus and the vagina end. So this is the tracheostomy. Here can be going to be performed. Okay, and we here can use this open abdominal and the vagina by manual routine of invasion routes, and the vaginal approach can be planned and removed by the laparoscopically, and the frozen section can be used as the confirmed by the negative nodes. If the negative nodes we can use as the frozen section and other procedure can be radical tracheotomy with the vaginally. So this can be on a need and the demand, and if especially the pathological method as a radical tracheotomy done as a second surgery after the first week. Okay, then we have again, if the stage is 1B2 and 1 is the same procedure is going to be applied at the radiotherapy and the primary treatment, especially that depended on the patient factors and the local sources and the surgical outcome. So here the advantage of surgical treatment, what we have feasible the determination of a post-operative stage, and the preservely is based of histological finding, and there may be the individualization of the post-operative treatment. So according to the stage and the post-operative the treatment, we have to visualize and individualize the patient, and according to situation we have to be managed. So can be restricted of some patient with the radiotherapy. So if they say to be the ovaries are functioning, and the intraoperatively the transposition of the ovary. So here they say to we have to be go as the radical field to be the is a feasible for a patient, and we will go to be the patient with prevention of ovaries and sexual function is making to surgery performed by the younger women, especially if we are going to be with the deal with the younger females. Though this type of the radical hysterectomy is a standard procedure for the treatment of a cervical cancer, consisting of a removal of a uterus or the parametrium. So upper vagina is a part of the column and with a pelvic lymphodectomy. So adjuvant, here we have the adjust with the connective tissue, and this is the deep the surgical involvement, surgical procedure is going to be involved with the patient. So figure stage here the 1B2 and 2BA. Here they say to be the cervical cancer. The surgery is will go to the radiotherapy with chosen by primary treatment. So if the patient with the came to you, the 1B2 and 2A1, this stage is the cervical cancer is going to be the surgery and or the radiotherapy. So choose by the primary treatment depended on the patient factors, local sources, and the similar we have to be see the advantages of the surgery, feasible of a determination and the post-operative care, and the previously the basis of a histological finding especially. So and the post-operative even the treatment though, so possible the treat cancer and the resistance of the radiotherapy also. And we can go to its conservative ovarian function with a patient with the field of the radiologically. So we have here the figure stage 4A recurrence with the really patient with the stage 4A disease and only the central disease, so without involvement up of the pelvic side wall. And this is not as distended with the spreading such. So here the recurrence of the pelvic extraction and the consider usually as a poor prognosis. So radiation management can be go, and the radiation therapy can be go as a disease of the stages like 1A, 1B and 1B2 and the 2A. This is going to be as a radiation therapy with the staging. So okay, then we have the adjuvant therapy. We have some drug to be going to be as adjuvant therapy, especially we will go the follow of our radical hysterectomy support with without chemotherapy. So indication with the patient with the advantages the advantages of the pathological factor according to various perspective, the prognostic the category of the high or intermediate or the low risk according the condition, the risk, and the stage of the disease. So here the positive surgical margin lymph node metastasis parametrial spreading, and the patient will offer to port and the chemotherapy and port chemotherapy. And if the patient is said to be the intermediate with the 2 or 3 factor with this one, and size is 4 centimeter, and lymphovascular invasion and deep stromal invasion is required as the port 776. So this is the different we have here the adjuvant therapy to be going to be according to stage. So radiotherapy even figure stages according to 1 to be to this is a very advanced, even going to be the managed as a feasible of initiate the treatment by the staging. And here we can even go to airport or the CCRT, the staging of management. So they said to be here the 80% them is required the port and CRC. And the radiation therapy for a figure staging and 2B and the 4A is going to be in the CCRT significantly advantages like 10 to 15% for a 5-year treatment comparing with the radiotherapy alone. So according the condition we will going to be the manage the patient and get the benefit. So if they said to be the completion of a radiotherapy protocol within the speculating with the important the goal and the direction correction with the outcome. So here the retrospective analysis patient who will going to be the radiotherapy and the treatment exceeding more than 9 to 10 week has been the significant higher rate of a pelvic failure. So comparing with the woman with the treatment and was completed less than 6 to 7 weeks. So secure recommendation complete entire protocol by a BART and the brachytherapy with the 8 weeks. So this is a very important. And second we have this small table, table 3, the field designed by the pelvic radiotherapy, especially this is according to this one which the side is going to be involved, if superior and inferior and the lateral, according to this we have to be managed, even the size. So this is even important, but this is very advanced condition going to be the managed. So if the stage is going to be 4B distended metastasis and the involvement of the metastasis with the condition and like 7 month, approximately, the disease is metastasis. So better response of the systematic chemotherapy overall of disease free, like 69 to 57% respectively. And here, especially the patient with the positive para-aortic or the supraclavicular lymph node. And the prophylactic, here they said to be there is a no role of the prophylactic field of the radiotherapy and the local advanced cancer. So here, when the para-aortic lymph node involved are EFRT, we have to be with a concurrent chemotherapy should be used. So this is even the multiple drug we are going to be used according the patient need. So if the low response is plastic, the chemo radiation, the recent evidence they found that platinum is maybe double, and the cisplatin is along with a very the modest benefit can be red will come. So cisplatin can be combined with the taxane and the topotaxin 5-fluorouracil and the gemcitabine and venorilbin and the carboplastin. This is combined, and the treatment we can successfully manage the patient and go to the treatment of the patient. If we will go to the radiotherapy after the going to be complete surgery, so what we have to be we will have to be in vision of a cervical cancer, maybe the found during the pathological evaluation. So a specimen for a simple hysterectomy is is a begin condition. So here the unadvantage, a simple hysterectomy is considered as a disadvantages of the surgery in vision of the carcinoma, and subsequently the therapy required all such cases. In such situation, we have to be to be assessment by the radiology, especially extension PET and the CT, if the available, and the pelvic and the abdominal CT and the MRI and the chest images. To be the patient, if is going to be the advantage or the incomplete or the complete therapy are going to be effect of any the treatment is going to be as surgical or the after surgical to be look on the advantages or the disadvantages. So we have to be go again to see and assist the patient by the radiology. So post-treatment follow-up, they said to be systematically they found to be the 7 to 36 after the primary treatment, and then clinical the close, if the clinically the close-up follow-up this will be the first 2 to 3 years after the treatment is important, and the routine follow-up can be 3 to 6 months, and the first 2 to 3 years every 6 months, and till 5 years. This is the follow-up especially is 5 years. Even here the annually and for to be taking to be history, even the examination and the complete the psychological and the routine like images, especially images is not recommended, but here they say to be if the involved is the higher pelvic lymph node and justify that interval image and the abdominal access can be potential and the progress of the disease, especially this is the patient condition and the circumstances, especially the further investigation or the assessment. So recurrence can be maybe the local or the pelvic and the para-aortic lymph node with the developed distended metastasis. The maybe it is combined with the risk of the failure of increasing proportion of the tumor, and the most recurrence can be within the 3 years. So prognosis can be the poor, most of the patient, and the die is a form of the progressive disease. So most common we will say to be the treatment may be dependent on the patient performance of a status and the site, even the recurrence of the metastasis. So this is even recurrence can be we have to be deal. So local recurrence can be the most site of the recurrence can be good prognostic factor involved that and that's said to be the if the less than the 3 centimeter, if the less than the 3 centimeter largest diameter, the disease can be cured with the pelvic previous therapy, and they said to be by the treatment, the radical chemotherapy and the pelvic extension. And this is a confirmation by pathologically by the biopsies, and that is essential prior to the proceeding. And radical radiation with 5-year the treatment with the resulting and can be survival rate will go to 45 to 74%. Isolated pelvic failure after the primary surgery. So this is even important to the follow-up and the which treatment is going to be given. Especially here the para-aortic node is recurrence can be occur, like they said to be the most common recurrence they found in the para-aortic lymph node. So this is approximately the long-term chemoradiation, like 30% cases. And the compressive palliative the care can be will go as a symptomatic, and the quality and the involvement and the damage in the structure according to this one we have to be managed, and the palliative treatment we have to be see. Okay, this is a very special condition when the patient with the cervical cancer and the patient is pregnant. So adequate management the patient is required for multidisciplinary team. As a plan must be discussed with the patient, and ideally if the partner is to or order to respect the wishes, and the broadly we have to manage with the cervical cancer, especially the pregnancy follow-up. The same the principle is non-pregnant patient. So here before the 16 to 20 week of a gestation, the patient treat without delay. And if the mode of therapy is either the surgery or the chemo radiotherapy, it depended on a stage of a disease. So radiation often risk of a spontaneous abortion of a conception. This we have to be in keep our mind. Okay, form of the late, if the patient is in the form is a late stage of a trimester 2 or 2, the surgery or the chemotherapy must be selected of a case and preserve the pregnancy, while the diagnosis as can be made after the 20 weeks. So the dying is definitive treatment is a valid option according to stage. If 1A2 or 1B1 or 1B2 has not been shown as having any negative impact of the prognosis compared with a non-pregnant patient. So time of a delivery is required the balance between the maternal and the fetal health and interest especially. So the delivery at a tertiary center with the appropriate neonatal care delivered by the classical cesarean section and the radical hysterectomy at the same time undertaken not later than 34-week gestation. So for the more advanced disease, if the patient with the suffering with the more advanced disease, impact of the treatment can be delay of a survival or not to be known. So here the new adjuvant chemotherapy may be administered and to be the prevent disease of the progression in the woman, and the local, especially the local advanced cervical cancer, and the treatment maybe we can make a delay plan or according the situation of the patient we can manage. Okay, alhamdulillah, I finish my topic here. Thank you guys. If you like my discussion about the Hpv cancer 2021, if you have get any benefit, please like and subscribe my channel. Thank you so much.